Hello, everybody. My name is Jan de Waele. I work in Ghent, Belgium, and today I will be talking to you about severe acute pancreatitis, one of the most challenging abdominal conditions you will encounter in a surgical ICU. These are my disclosures, none of them, in fact, relevant for this particular presentation. Now, before we start, I do want to warn you that this is a topic where dogmas have been ruling the management for a long time, and not only in the ICU. But in the past 10 to 15 years, I think we learned a lot that helped us improve the management of patients with acute pancreatitis, and this is what I would like to discuss with you today. If you treat patients with acute pancreatitis, I'm sure you will agree with me that pancreatitis is a complex disease. And I want to highlight some basic concepts that help us understand pancreatitis as well as manage the complications thereof. This is a highly inflammatory disease, unlike any other. This inflammation will determine the early phase and also will also affect the downstream complications as well. Pancreas has a specific anatomical situation. It's related to a lot of important organs and vascular structures in the abdomen. And as there is no real capsule, any disease from the pancreas spreads to the surrounding organs quite easily. And this is something we see every day when we treat patients with pancreatitis. And this results often in a protracted course for the patient, not only in the ICU, but also in the general ward and in the hospital. And it often has important long-term consequences. Now, when we admit a patient to the ICU, it's important to realize that you're only seeing the tip of the iceberg. The majority of the patients develops mild disease. They may be admitted to a general ward in the hospital. Most of them are actually not admitted to the hospital, and it's only a few of them that actually need ICU support. It's a highly selected population, but they are also at the highest risk of all the bad things you know about pancreatitis. Pancreatitis and its complications can be divided into two categories: early and late complications. Early complications happening, say, within the first week. And the inflammation is really what drives things here. It leads to multiple organ dysfunction and can be very fulminant. The patient can be from walking around to being on a ventilator and continuous renal replacement therapy in 24 hours. Abdominal compartment syndrome is one of the central problems here, and preventing and treating it, which I will discuss in a minute, is certainly an important feature of this early phase. The late phase is governed by infectious complications of pancreatic and peripancreatic tissue, can be highly fulminant and present with septic shock, but some patients have infected necrosis and fare very well and may not even be in the ICU. Now, this is also reflected in what we see in the pancreas and peripancreatic tissues on CT scans. This, for instance, shows you an inflamed pancreas with some peripancreatic fluid. This is the early stage, and this may develop into peripancreatic necrotic collection, as you can see here. Still often the first 2 to 3 weeks of the disease, and it's only at a later stage when you get this picture of the walled-off necrosis and a persistent collection with a thick wall, as you can see, and this will require an intervention in most situations. So let me first focus on the problem of abdominal compartment syndrome, something we've been working on a lot and which I think is an important problem in patients with acute pancreatitis. So how does acute pancreatitis lead to abdominal compartment syndrome? There's a huge problem of retroperitoneal inflammation. I told you the pancreas is leaking to the retroperitoneum. It's a huge space. There's no capsules or anything, and you see that the whole inflammation, the whole region can be inflamed. That may also result in ileus and obstruction and ascites, contributing to the increase in intra-abdominal volume. And I do specifically want to mention the use of fluid and fluid overload, fluid over-resuscitation as a particular situation, a particular problem leading to abdominal compartment syndrome in these patients. So you see many reasons for patients to develop abdominal compartment syndrome. Now, while most of these studies are already a little bit older, actually more recent data confirm this. In about 1 out of 4 to 1 out of 2 patients with acute pancreatitis, they will develop abdominal compartment syndrome. And it has important consequences. The increased intra-abdominal pressure or the intra-abdominal hypertension has both systemic and local consequences. Now, of course, we know very well about the systemic consequences, about the shock and acute kidney injury it can cause, and also the respiratory insufficiency that is often an early sign of abdominal compartment syndrome. But specifically in acute pancreatitis, the local effects are not to be underestimated. Intestinal hypoperfusion is one of them, leading to contributing to necrosis, no doubt, and also bacterial translocation, which in itself may contribute to pancreatic infection. So the intra-abdominal pressure increase not only explains in a lot of patients why they have severe symptoms in the early stage, systemic symptoms, but also why they may develop later complications as well. So it's important to prevent and manage this. So what can we do about this elevated intra-abdominal pressure? Well, fluids contribute to an important extent to intra-abdominal hypertension. So careful fluid resuscitation is important. And I'm not saying that we shouldn't be giving these patients fluids. We should just avoid fluid overload. There used to be a time where patients with acute pancreatitis would receive 10 to 15 liters in the first 24 to 48 hours of therapy. And I think this is to be avoided as much as you can. Simple things as nasogastric decompression, of course, can also help to prevent intra-abdominal hypertension from developing. And if it develops, there's several things you can do. You can start, of course, easily first with draining any residual ascites percutaneously, or going for a surgical intervention when all of the above does not help. And while we've been able to avoid a lot of decompressive surgery in our patients, we still need to resort to decompression in some patients. When we do it, we use a midline laparotomy. It's very effective. We do open the fascia, and not like in this particular patient, where we decompress the fascia, but we didn't open the peritoneal cavity. This was done at a later stage. And temporary abdominal closure techniques should be used because they will help you also to evacuate the fluid and decrease the residual edema. It's critical not to do any debridement at this stage and leave the peritoneum intact when possible. So at the bedside, how to manage abdominal compartment syndrome? Well, first of all, you need to think of it. You need to think of it in every patient with severe disease. That means in virtually every patient admitted to the ICU, and monitoring the intra-abdominal pressure should be done routinely. Prevent it where possible. Simple things, and fluids is the first strategy, of course, to try to prevent. Restricting fluids is the first strategy to try to prevent this. And non-invasive therapy if it develops with surgery as a potential option still. The rest of my talk, I'd like to focus on the management of infected pancreatic necrosis. Because I think this is really one of the biggest challenges in patients with pancreatitis. Diagnosing the infection on the one hand and managing the infection on the other hand. Now, when you think of pancreatic necrosis, it's important to realize that this is a very rare finding in the first 1 to 2 weeks of acute pancreatitis. These graphs nicely show you that a lot of patients may develop infection and pneumonia or bacteremia, but infected pancreatic necrosis, which is in white, you can see it very nicely here, that it typically develops after 3 to 4 weeks. And after 4 weeks, it's the most prevalent infection among patients who present with infected pancreatitis patients who present with infection. There's been a lot of literature looking at the effect of antibiotic prophylaxis. Literature studies that were done in the 1990s and early 2000s, but I think it's pretty clear by now that there is no role for antibiotic prophylaxis at all. And these infections occur late, and an early intervention will not help. It only changes the microbiology, and you will select antimicrobial resistant organisms. So the million-dollar question then is, okay, who is infected and how do you make the diagnosis? Chances are high that you will make the diagnosis based on a CT. It can be a typical CT scan, as you can see here, where you can see a large pancreatic collection with some air bubbles that are pathognomonic for infection. But this is only a minority of the cases. Yet still, upon clinical suspicion, a CT scan is definitely the way to go. If you see these acute necrotic collections with gas, absolutely, this is highly suspected of infection, and these patients should be treated. If there is no gas present, the next step would be a fine needle aspirate and microbiological examination of that aspirate to see if there's any bacteria present. And if it's positive, clearly, then we have a high suspicion of infection. Now, mind you, you don't have to wait for cultures. This is about microbiological direct examination. If it's negative, you can do conservative treatment, and still, of course, you need to support the patient and regularly reevaluate the patient as well. Antibiotics, of course, are important. They are only reserved for infections. I told you already about that. Typical enteric bacteria, it behaves like an abdominal infection with often nosocomial components, of course, particularly in patients who have been exposed to antibiotics before. Fungi, also an important problem, again related to prior antibiotic use. And the duration is often challenging. As in other abdominal infections, 7 days is the standard duration. If the source control is imperfect, which it often is, longer courses may be necessary. So at the bedside, consider infection in a patient who is deteriorating. As I mentioned, it is rare in the first week. It can be, but it is rare. An investigation with CT scan should be the next step. No prophylactic antibiotics, multidisciplinary approach. And this is really important because you need your surgeons and your interventional radiologists to help you with the management of these patients. How to treat surgically, just a few slides on surgery. I do have a surgical background, so forgive me to highlight a few of the surgical options because I think it's important for us intensivists to understand what the surgical options are. Now, the first thing I want to emphasize is surgery early in the disease has an increased mortality. So try as much as possible to avoid this. And this specifically relates to the debridement, not so much to any decompressive surgery for abdominal compartment syndrome. When surgery is necessary, a midline laparotomy has actually little value in these days. Most of the situations would be a retroperitoneal debridement, access to the retroperitoneal space, and thereby avoiding all the important structures in the abdomen. Another option is a transgastric approach. You may have seen this already. You make a hollow perforation in the posterior wall of the stomach and try to evacuate all the necrosis and the infection of the stomach. And a recent study indeed has shown that it to treat patients. And finally, just one picture to help you remember that this is how pancreatitis intra-abdominal pressure monitoring is a mainstay of therapy. You can use it to guide treatments. You can use it to drain ascites and decompress the patient if necessary. Fluid overload to be avoided. No antibiotics without infection, and no probiotics either. When infection is suspected, investigations are needed, and a step-up approach is necessary in case of infection. What surgical strategy is preferred? Well, this needs to be defined on a patient-to-patient basis. And with this, I would like to thank you and end my presentation.